Hello, my name is Christine Garver-Apgar, and I'm a research associate at the Behavioral Health and Wellness Program. Today, I'm going to be presenting information on tobacco cessation pharmacotherapy. We're going to cover a lot of material today, including how nicotine acts in the brain and the biology of why nicotine is so addictive. I'm going to describe the symptoms and patterns of nicotine withdrawal, and I'll provide information on all approved tobacco cessation medications, both those containing nicotine and those that do not, as well as combination therapies. And I'll discuss special considerations for specific populations of people. The clinical guidelines for treating tobacco use and dependence states that although both counseling and medication are effective when used by themselves for treating tobacco dependence, the combination of counseling and medication is more effective than either is by themselves. So clinicians should encourage all individuals making a quit attempt to receive both counseling services and medication. The reason that counseling and medication together are most effective at treating tobacco dependence is because tobacco dependence has two parts. Pharmacotherapy addresses the first part of tobacco dependence, the physical addiction to nicotine, whereas counseling addresses the second part of tobacco dependence, which is the habit or the behaviors surrounding tobacco use. We will be focusing for this presentation on the left half of this figure. So that's the pharmacotherapy as a way to address the physical addiction. I'll start with giving some information on the basic biology of nicotine addiction. We all know that nicotine is an incredibly addictive drug. But what we may not know is that nicotine is so addictive that individuals who have addictions to other substances like alcohol, heroin, or cocaine very often report that tobacco was the most difficult addiction for them to overcome. More people who try nicotine will become a daily user of nicotine than those who try other drugs. And it's also true that a greater percentage of those who try nicotine just a single time will become daily users than those who try other drugs like cocaine or heroin, even just a single time. Nicotine addiction is really no different from any other addiction other than being harder to quit. People use addictive substances because there are rewards from using them. And so in this module, we're focusing on the biological rewards of nicotine addiction. This would be things like feelings of arousal and pleasure. All drug addictions involve physical dependence. And what we mean by that is experiencing both tolerance to a drug as well as withdrawal. As tobacco users become more tolerant, they must increase nicotine use, either to get the same biological rewards or to simply avoid the negative symptoms of withdrawal, which leads to craving and then to greater addiction. So why is it that nicotine is such an addictive drug? Part of the reason is that tobacco companies have spent many, many decades now perfecting how to get nicotine to the brain as fast as possible. Because the faster nicotine gets to the brain, the faster an individual experiences behavioral reinforcement for smoking, and the more addictive it becomes. And what tobacco companies have come up with is the cigarette. Tobacco leaves are burned at very high temperatures, and the resulting smoke is inhaled. Each cigarette delivers about 1 to 2 milligrams of nicotine, and this is going to be important to know for dosing nicotine replacement therapy, which we'll talk about in a few minutes. After a person takes a puff of a cigarette, nicotine from that inhalation will reach the brain within 10 seconds. If nicotine had been administered intravenously, it would not reach the brain that fast. So this is a very efficient and quick way of getting nicotine to the brain. Because it reaches the brain so fast, smokers can easily control how much nicotine they get, which makes cigarette smoking more reinforcing than nicotine obtained in any other way. And that's why nicotine from other sources like the nicotine patch or gum or other sources of NRT have much lower potential for abuse. Just like cocaine, heroin, and amphetamine, nicotine stimulates the release of the neurotransmitter dopamine in the midbrain. This pathway is called a reward pathway because dopamine induces feelings of euphoria and pleasure. This is the same pathway that causes people to drink when they're thirsty, eat when they're hungry, and have sex and reproduce ourselves. For most of human evolutionary history, having a system that reinforced behaviors which tended to keep us alive and reproducing was a good thing. But nicotine has hijacked this system. The pleasure felt during these activities ensures that the behavior which led to them will be repeated. So when smoking a cigarette, nicotine enters the brain, stimulates the release of dopamine, which induces a near immediate feeling of either pleasure or simply a relief of symptoms of nicotine withdrawal, which we'll talk about more in just a minute. This rapid dose response and the fact that people can regulate their own levels of nicotine on an hour-by-hour basis reinforces and perpetuates the smoking behavior. Dopamine is the primary neurotransmitter that nicotine acts on, but nicotine stimulates the release of many neurotransmitters, all with different effects described here. It can lead to improvement in short-term memory and attention, faster cognitive processing, relaxation, stress reduction, decreased pain, mood improvement, and appetite suppression, although some of these effects may actually be just relief from nicotine withdrawal. Nicotine doesn't just have effects in the brain related to dependence, of course. It also can lead to other physical effects, things like increased heart rate, increased blood pressure and vasoconstriction, increased metabolic rate, increased sleep disturbances, insulin resistance, just to name a few. Almost every system in the body is affected by nicotine in one way or another. Initially, nicotine can sometimes cause unpleasant symptoms like nausea, dizziness, coughing. These adverse effects quickly diminish with repeated tobacco use. And for some people, even these initial effects of nicotine are positive. So people would describe nicotine as giving a pleasurable buzz, even the first time they use it. When people stop using tobacco products, and depending on their level of use, they will very likely experience some or all of the symptoms mentioned here. And usually they will experience a strong desire or a craving for tobacco. They can also experience symptoms of depression because taking away nicotine has the effect of reducing dopamine and serotonin activity in the brain. In general, withdrawal symptoms appear within the first 1 to 2 days. They peak within the first week, and they gradually dissipate over the next 2 to 4 weeks. So they're most intense within the first few days or the first week, and then they gradually get better. And if you compare this with heroin, where withdrawal symptoms decrease substantially after only a day, nicotine withdrawal can hang around for weeks. And not only that, but cravings and urges for cigarettes can take much, much longer, even months or years to go away after quitting. When somebody is experiencing symptoms of withdrawal, counseling is not particularly effective, which is why pharmacotherapy in combination with counseling can be so helpful. And now I just want to take you through a day in the life of a smoker. So this image depicts a smoker smoking one cigarette every 40 minutes between 8 in the morning and about 9 p.m. at night until they retire for the evening. The jagged line here represents venous plasma concentrations of nicotine as the cigarette is smoked. The shaded area of this curve indicates plasma concentrations of nicotine where a person feels just perfectly comfortable. So they're not experiencing pleasure or arousal from smoking, but they're also not experiencing withdrawal symptoms. The area above the curve would indicate a venous plasma concentration whereby a person is experiencing positive rewards from smoking, so arousal or pleasure. And the space underneath the curve would depict the area where a person would be feeling lousy or would be feeling negative withdrawal symptoms. And what I want you to notice about this figure is the arousal or pleasure people experience after smoking the first cigarette of the day. Nowhere else on this addiction curve do you see a jagged line go so high above the comfort zone and into the pleasure zone. So this is why many smokers will say that their most important cigarette is the first one of the day, and how quickly somebody smokes that first cigarette of the day is actually an indicator of tobacco dependence. The reason the first cigarette is the most pleasurable one is because tolerance starts to develop shortly after that first cigarette. And as smokers become more tolerant to nicotine throughout the day, they get less pleasure out of each cigarette. And instead, they simply get relief from nicotine withdrawal. Overnight, a smoker becomes resensitized to nicotine, and then the cycle starts all over again the next day. With cigarettes, smokers can easily regulate how much nicotine they're absorbing, and so there is wide variability in how much nicotine one cigarette can deliver. It depends on a lot of things: the puff volume, the depth of inhalation, the rate of puffing, the intensity of puffing. There are also ventilation holes that smokers often don't know about and will either consciously or unconsciously block with their lips or fingers while smoking. And this also increases the amount of nicotine that people can absorb. So the idea that light cigarettes deliver less nicotine is really a myth, because smokers will simply compensate their puffing behavior so as to give themselves a steady dose of nicotine. Now, just a word on metabolism. Most nicotine, about 85 to 90%, is metabolized in the liver by a major liver enzyme called cytochrome P450. And I'm bringing up metabolism because the system that metabolizes many of the toxins and carcinogens in cigarette smoke is the same system that processes many psychotropic or psychiatric medications, as well as caffeine. And so this is going to become important when we talk about smoking cessation and folks who are taking psychiatric medications towards the end of the presentation. So now I'm going to go through all of the tobacco cessation medications that have been approved by national regulatory agencies and give you some information on each one. Why should people use a medication for quitting? After quitting, withdrawal symptoms can be so uncomfortable that they often relapse. Cessation medications work by helping to alleviate nicotine withdrawal so that people can focus on working to change their smoking behavior and be comfortable while they're doing it. And most importantly, cessation medications improve a person's chances of quitting. And we'll go through some data slides in a few minutes illustrating that. This slide lists the 7 medications that have been approved by the FDA for smoking cessation. 5 of these contain nicotine, and they are called nicotine replacement therapies, or NRT. 2 of these do not contain nicotine. 3 of the NRT medications are available without a prescription: the nicotine patch, the nicotine gum, and the nicotine lozenge, whereas the remaining medications all require a prescription. That would include the other 2 forms of NRT, the nasal spray and the nicotine inhaler, as well as the medications that that effect of tobacco cessation by using other mechanisms, which we'll talk about, bupropion and varenicline. So NRT, the safety of NRT has been very well established. It has very few side effects. There are no known drug interactions with psychiatric medications, with the exception that using a combination of NRT and bupropion can increase the risk of hypertension. However, the FDA still approves combination therapy with bupropion and NRT, which I'll go over in more detail in just a minute. NRT can also be used safely by individuals who have stable cardiovascular disease. It can be used safely by people with COPD, and it can be safely used, and it's even recommended when individuals are still smoking or prior to a quit attempt. So now we'll go through each one. First up is the nicotine patch. The patch is available without a prescription in 3 strengths, either 21 milligrams, 14 milligrams, or 7 milligrams. Nicotine is delivered to the body through the skin. Nicotine begins to be absorbed 1 to 4 hours after the patch is applied, and the highest level of nicotine in the body happens about anywhere from 3 to 12 hours after the patch is put on, depending on the brand. So this is not a fast-acting hit of nicotine. This is the most slow and steady version of NRT available. The patch should never be cut in half because nicotine is immediately released through the cut portion, and a person could receive too much nicotine all at once rather than getting the sustained release that they're intended to deliver. So don't cut the patch in half. The patch should be placed directly on the skin, somewhere on the upper body where there is not a lot of hair, like the upper arm or the upper back. It should be replaced every 24 hours, and it should be worn all night long unless it causes sleeping problems, which it can. That's one of the side effects. The patch should be moved around to a new location on the body every day, because the nicotine and the adhesive can cause some skin irritation. And while up to 50% of patients do experience this reaction, fewer than 5% discontinue the patch as a result. But that said, the patch should probably be avoided in patients who have dermatologic conditions like psoriasis or eczema, or who have a known allergy to adhesives. Although if the adhesive is the problem, you can try switching to a different brand, and that will sometimes alleviate that problem. The patch is recommended if individuals smoke at least half a pack per day. If a person is smoking less than that, then you might try either a 14 milligram patch or some other form of NRT would be recommended in that case. The starting dose of the patch is based on how much tobacco a person is using. So remember that if each cigarette delivers between 1 and 2 milligrams of nicotine, somebody who is smoking a pack a day is getting between 20 and 40 milligrams of nicotine per day. And so that person should be starting with a 21 milligram patch. If a person smokes 2 packs per day, they should start with 2 21 milligram patches. Expert opinions of dosing NRT vary quite a bit, but there is growing consensus that NRT is often underdosed, and that leads the user to believe it simply doesn't work for them, which is unfortunate. Okay, just some tips for applying the patch. You would peel off a half of the adhesive backing, apply the adhesive exposed side to the skin, and then you would peel off the remaining backing and press firmly with the palm of your hand for about 10 seconds to make sure the patch is firmly adhered. And remember to have patients carefully dispose of the patch after they take it off every day. It still will contain some nicotine at this point, and so folding it on itself to prevent pets and or children from getting to it is a safe way to dispose of the patch. Okay, nicotine gum. Nicotine gum is sold by the brand name Nicorette, which is shown above. It's sold as a generic, and it's sold under a new brand name, Zonic. Nicorette and the generic versions are sold in large boxes containing 100 doses of gum, as well as smaller boxes containing just 20 doses. Zonic, though, is popping up in gas stations, and it's sold in quantities of 10 with a disclaimer that this dose may not represent a full day's supply. It's available in different flavors, and it's sugar-free. It's absorbed, the nicotine from nicotine gum is absorbed through the lining of the mouth. And it is sold, of course, without a prescription. The gum comes in 2 doses, 2 milligrams or 4 milligrams. Most folks are going to start on the 2 milligram dose, but people may want to start with the 4 milligram dose if one of a few things are true. So if they smoke more than a pack a day, if they smoke their first cigarette as soon as they wake each morning, if they have severe withdrawal symptoms when they don't smoke, or if a lower dose has not been successful at helping the person to quit, they might want to start with the 4 milligram dose. The general manufacturer's recommendation for nicotine gum dosing when it is used alone and not in combination with any other treatments is to use no less than 9 doses per day and no more than 24 doses per day. The nicotine gum is one of these forms of NRT that is frequently used incorrectly. So, clients need some instruction on using the gum correctly. Otherwise, they might think it is just not working for them. What clients should do is chew each piece very slowly until the gum releases a peppery taste or a slight tingling. This is the nicotine being released out of the gum. Some people will say it feels like a cool sensation. At that point, when the nicotine is released from the gum, they should park the gum between their cheek and their gum and just keep it there. And that will allow nicotine to be absorbed across their buccal mucosa. Then, when that tingle goes away, they resume chewing it just long enough for that tingle or that sensation to come back, and then they park it again. And they just repeat that chewing and parking process until the tingle has faded from the gum completely, and that takes about 30 minutes. Because when people just chew it, what happens is most of the nicotine just gets swallowed, and it doesn't get absorbed at all, and so it's, of course, not effective in that case. The nicotine lozenge also comes in 2 milligram and 4 milligram strengths. It's available without a prescription as well. It comes in different flavors, just like the gum, and it's meant to be taken like other lozenges or cough drops, sucking on one until it completely dissolves and moving it around from place to place in the mouth. Because the lozenge dissolves completely, unlike the gum, it provides about 25% more nicotine than a comparable dose of nicotine gum. So if you had a 2 milligram lozenge and you had a 2 milligram piece of gum, you're going to get more nicotine out of the lozenge than you would out of the gum, because some nicotine still stays in the gum a little bit. For both the gum and the lozenge, acidic beverages should be avoided for about 15 minutes before and also during use, because this interferes with nicotine absorption. The acid interferes with nicotine absorption across oral membranes. The nicotine nasal spray delivers nicotine through nasal membranes, and this is available only with a prescription. 1 dose of the spray would be 1 spray in each nostril, and a bottle contains about 100 doses, which would be a 1-week supply for most people. Nicotine is absorbed more quickly with the nasal spray than with any other form of NRT. So this is actually the form of NRT that's most similar to a cigarette in the sense that plasma concentrations increase the most rapidly with the nasal spray compared with any other form of NRT. Side effects, as with any nasal spray, can include some nasal irritation or congestion or changes in smell or taste. People don't need to sniff the medication while they're administering it like you would with some other nasal sprays, because this can increase the nasal irritation. The nicotine inhaler is also sold only with a prescription. It comes with a mouthpiece and a plastic cartridge. Each kit comes with about 42 cartridges, and each cartridge delivers about 4 milligrams of nicotine, and that's absorbed through the lining of the mouth. The manufacturer recommends starting with at least 6 cartridges per day during the first 3 to 6 weeks of treatment. That would be like 1 cartridge every 1 to 2 hours with a maximum of 16 cartridges daily. The inhaler is designed to be similar to smoking in that it replicates the act of holding and putting a cigarette up to your mouth. And this can be a good or a bad aspect of the nicotine inhaler depending on your view. It may reinforce that hand-to-mouth behavior of smoking more so than any of the other NRTs, and some clients are not interested in having that behavior reinforced, and so this would not be a good choice for them. Okay, just a quick label update. There used to be a warning on the label of NRT products that a person should not use the product while they're still smoking or using other nicotine-containing products. However, these warnings have been removed because there are no significant safety concerns associated with using NRT products with other nicotine-containing products, including cigarettes, simultaneously. Nor are there any safety risks associated with the use of NRT products for longer than the labeled number of weeks of use on the packaging. And this is routinely done, using these products for longer than what the label specifies. And as well, current marketed NRT products do not appear to have any significant potential for abuse or dependence. And so the labels have been changed to relax these original concerns. Bupropion sustained release is actually a medication commonly used to treat depression. When it is used to treat depression, it's called Wellbutrin. When it's used to treat tobacco cessation, it's called Zyban. It's sold with a prescription, either as Zyban or as a generic. The medication does not contain nicotine, and its efficacy at treating tobacco dependence appears to operate independently of a person's depression history. So in other words, it's been shown effective for tobacco cessation among individuals who have and who do not have a history of depression. Bupropion may also reduce weight gain associated with tobacco cessation, which can be helpful for some people. The initial dose is 150 milligrams per day for 3 days, followed by 150 milligrams twice daily for another 6 to 12 weeks, although this medication can be safely used for longer than that. Longer-term use, in fact, may help reduce or delay relapse to smoking. And this medication can be stopped abruptly. It does not require tapering. Insomnia is the most common side effect of bupropion, but there are a few others listed here. Dry mouth, some agitation. There are some contraindications for bupropion or situations in which a treatment using bupropion would not be advisable. Bupropion can lead to a higher incidence of seizures. So for folks who are already at a higher risk of seizures, bupropion would not be advised. This would include people who suffer from eating disorders or other seizure-related disorders. And for those with bipolar disorder, bupropion is also not advised because it can precipitate mania. And both bupropion and varenicline, which I'm going to talk about in just a minute, have a black box warning. So I'll talk about that when I get to varenicline. Varenicline is sold as Chantix with a prescription. Like bupropion, varenicline does not contain nicotine. It works in a couple of different ways. It mimics nicotine in the brain, so it helps to prevent withdrawal symptoms, but it doesn't have as strong as an effect. And so it blocks the places in the brain where nicotine would normally work, but it doesn't produce quite as strong of a signal. And so what people will say is that when they're taking varenicline, if they smoke a cigarette, they really don't get any effect from the cigarette. They don't feel the same rewards. The initial dosing is 0.5 milligram per day for 3 days, and then twice daily for 4 days. And then for the next 11 weeks, the dose is 1 milligram twice daily. The most common side effect of varenicline is nausea, which often disappears over continued use. Folks can take this medication with meals, which can help. Also, many people experience vivid dreams while taking varenicline. They're not nightmares, but they may still be disturbing to some people, although other people report quite liking the vivid dreams. Like bupropion, varenicline has a black box warning. A black box warning is used when a prescription drug that is known to be effective for some patients may cause serious side effects in others. So with both Zyban and Chantix, some people have reported changes in behavior or agitation, depressed mood, and thoughts of suicide when attempting to quit smoking. Because these symptoms resemble those that are associated with nicotine withdrawal, it's possible that some of these symptoms are a response to nicotine withdrawal and not to the cessation medication itself. But because of these findings, the FDA required a black box warning to be put on both of these medications. And because of the concern with agitation and thoughts of suicide and depression, independent studies have now examined the safety of varenicline, specifically in people with serious mental illness. And so far, these studies have found no significant safety concerns of varenicline within this population. But nevertheless, anybody, experiencing, as with any medication, something that they just feel is not right should stop the medication and see their provider right away. In March of 2015, so fairly recently, the FDA approved a few additional label warnings, specifically concerning alcohol. Until patients know how Chantix affects their ability to tolerate alcohol, they should decrease the amount of alcohol they drink. And so this sounds like, a lot of precautions and warnings on this medication, but I think it's always a good idea to consider what an FDA warning would look like if you saw one on a box of cigarettes. And so, like all prescription medications, it's important to be monitored by a physician, and these are no different, but they're safe medications and they're very effective. And that's what I want to briefly go through some data slides now showing the efficacy of these various medications at helping people quit and remain abstinent for various lengths of time. So this first table shows various forms of NRT compared to a placebo, and it's looking at abstinence 6 months out. So for the patch, an odds ratio here of 1.9 means that compared to people who received a placebo or a sugar pill during the study, people who received the patch were 1.9 times as likely, or about twice as likely, to remain abstinent for 6 months after quitting. And these other NRT products showed similar results. That previous slide was based on a meta-analysis of lots of studies' findings, all averaged together. But this slide is based on a single trial of the nicotine lozenge. And here it looks like individuals who received the 2 milligram dose were also about twice as likely to be abstinent at 6 months compared to those who received a placebo. And folks who received the 4 milligram dose were almost 3 times more likely to be abstinent at 6 months compared to those who received a placebo. Here, bupropion. Also, this is a meta-analysis of 24 studies, also finding that the medication makes it about twice as likely that somebody will be abstinent at 6 months if they use the medication in their quit attempt. And then this is a busy slide, but it's based on 2 studies comparing the efficacy of Varenicline, which is the yellow bar, with bupropion, which is the pink bar, and then comparing those to a placebo, which is the blue bar. And looking at whether people remained abstinent for at least 4 weeks after quitting, folks who received Varenicline were twice as likely as those who received bupropion to remain abstinent for 4 continuous weeks, and they were almost 4 times more likely to remain abstinent compared to those who received a placebo. And then these same 2 studies followed these people for an entire year. And what we see here is that Varenicline maintains its advantage even 1 year after quitting. And this graph compares even longer-term efficacy among the various tobacco cessation medications. These quit rates were maintained over 3 years. And in all cases, the takeaway from this graph is that the 3-year quit rate is higher for those using a medication than for those who just received a placebo. So in every case, the medication is more effective than not using it at helping people to remain quit for at least 3 years. Now, there are a few newer strategies for using FDA-approved cessation medications, so I'm going to go over those now. Researchers have found that cessation rates are higher when individuals used combination therapy rather than using one medication at a time. So in 2008, the clinical practice guideline recommendations were updated to include combination therapy. And the recommendations for combination use are shown here. It is considered safe to use the patch along with any other form of NRT. So a common way to do this would be to have folks use a patch for the steady dose of NRT, but when cravings hit and people need some reinforcement or some additional support, something that's a little more fast acting, they can use either the gum or a lozenge for those times when a craving strikes. It is also considered safe to use bupropion with either the patch, the gum, or the lozenge. And although using Chantix in combination with NRT has not been approved by the FDA as a combination therapy, prescribers will do this in practice, but it would still be considered off-label at this time. And here's just another data slide showing how combination therapy works. In this study, the nicotine patch was used long-term, so at least 14 weeks, and combined with either the gum or nasal spray or with the nicotine inhaler on an as-needed basis. 6-month abstinence rates were compared to a placebo. And recall that the patch on its own doubled the likelihood that a person would remain abstinent for 6 months. But in this study, we see that using the patch plus the gum or the spray as needed more than tripled this likelihood. So we see some increasing gains from using multiple therapies in combination with each other. Another strategy to increase the efficacy of NRT is to start using it before the quit date. It's very difficult to overdose on nicotine. People taking too much nicotine start feeling really lousy, nauseous, long before they would experience any significant long-term consequences of too much nicotine. And so providers have started using nicotine replacement therapies before an individual makes a quit attempt. And results from studies have shown that there are no increased side effects from this practice. And one study indicated that using the patch prior to a quit date doubled the success rate of that quit attempt compared with using the patch beginning on the quit date. So that's something to consider for clients. And now in the last few minutes, I just want to provide some information on special considerations when recommending pharmacotherapy to specific population groups. Okay, so I'll start with women. Among women in general, NRT is not as effective as it is in men. So when I said that medication plus counseling was more effective than medication alone, this is particularly true for women. Bupropion may be one exception because it is helpful at alleviating that short-term weight gain associated with tobacco cessation. And so this may be of particular concern for women, and it may be particularly helpful for them. For pregnant and nursing women, the recommendation is that pharmacotherapies not be used as a first-line treatment for tobacco dependence because they simply haven't been sufficiently tested in these populations. However, they may be prescribed women may be prescribed pharmacotherapy during pregnancy under the supervision of a physician. Some physicians will do it, some will not. Particularly, though, if women are very resolved to quit smoking during pregnancy, or if they've tried other strategies and these other strategies have not proven effective. Although NRT does expose a fetus to nicotine, and in fact, a fetus's blood levels of nicotine are about 15% higher than the mom's blood levels, whether it's NRT or nicotine from a cigarette, NRT is preferable to cigarettes because, of course, it doesn't contain all of the other harmful chemicals in tobacco, so long as the dose of nicotine remains at or below what a woman would be taking in just from smoking already. You wouldn't want to have women getting more nicotine than they would just from smoking. NRT for tobacco users under 18 is considered off-label, but it can be prescribed. It should be considered only when there is clear evidence of nicotine dependence and also a meaningful desire by the client to quit. So this is not for a kid who gets caught smoking, but who is not exhibiting nicotine dependence or who doesn't themselves really want to quit smoking. Generally, expert recommendations for giving pharmacotherapy to youth is fairly mixed. The 2008 clinical guidelines does not recommend NRT or bupropion for youth, for example, whereas other agencies will recommend much more aggressive treatment with NRT and other pharmacotherapy, especially for those over 16. So the evidence right now is fairly mixed, and expert recommendations are a bit conflicting. People with mental illnesses or addictions to other substances are often more nicotine dependent than tobacco users who are not struggling with these other conditions. These levels of addiction warrant intensive pharmacotherapy and counseling. There are no known medical reasons not to use the FDA-approved medications for tobacco cessation with this population. Particularly if inpatient treatment settings or hospitals are tobacco-free, it's especially important to offer cessation medications so that patients are comfortable during their temporary abstinence from nicotine. Studies have found that among psychiatric inpatients, those who are not provided NRT were 2 times more likely to discharge from their hospital against medical advice than those who were provided some sort of NRT during their treatment. People on psychiatric medications require special considerations when they quit smoking. And I alluded to this a little bit earlier when we were talking about metabolism. This is because the system that metabolizes many of the toxins and carcinogens in cigarette smoke also processes many psychotropic medications along with caffeine. It's important because tobacco cessation can affect the blood levels of many different types of medications. So, as tobacco users metabolize and excrete nicotine and other chemicals in cigarettes, they're also more quickly metabolizing prescribed medications. And what happens is when an individual quits smoking, blood levels of many of these medications can significantly and sometimes dangerously increase because metabolism slows down after somebody quits smoking. And so sometimes side effects of higher dosages of prescribed medications are actually confused with nicotine withdrawal or psychiatric symptoms. So it's very important that prescribing providers are aware that their patients are quitting smoking, and they need to be monitoring psychiatric medication levels in that case. Tobacco use and cessation has the same effect with caffeine. So individuals who use large amounts of caffeine may not be able to tolerate these levels any longer when they stop smoking. Again, because that metabolism slows down and the levels of caffeine increase in the system. And I would just like to close with this statement that everyone who uses tobacco should be offered an opportunity to make the decision to stop. And I want to just briefly put up some resources that the Behavioral Health and Wellness Program has on our website. We have lots of resources available. And so I encourage you to visit our website and take a look at what we have to offer. Also, if you have questions that this presentation brought up, or if you have other questions related to tobacco cessation, we are always happy to answer your questions, and we can be emailed at this address. And I thank you for listening to this presentation today.